Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Cindy Rubin. She is a pediatrician and breastfeeding medicine specialist. Her Kevin MD article today is Say No to Apno and Yes to Breastfeeding Medicine, and Apno being all-purpose nipple ointment. Cindy, welcome back to the show.
Thank you for having me.
We'll get into the article in a little bit, but for those who didn't listen to our first episode together, just briefly share your story and journey.
Sure. So I am a pediatrician, and as you said, a breastfeeding medicine specialist, and I am in the Chicago area. I was an academic outpatient general pediatrician for 13 years before I decided to venture out on my own, and I opened a direct primary care pediatrics practice, but also breastfeeding medicine and fourth trimester care practice where I do home visits, which is awesome.
And as a breastfeeding medicine specialist, tell us some of the top things that you would see in your practice.
Yeah, so breastfeeding medicine, I want to actually start by just making a distinction. A lot of people don't really understand what that is in relation to breastfeeding care and how it differs from lactation consulting. Lactation consulting is amazing and is the first line usually for breastfeeding issues or preventive breastfeeding care. And lactation consultants can give counseling and education around breastfeeding. Oftentimes, there are more complicated problems that require physician level care. So the things that I commonly see are persistent pain, breast pain, nipple pain, persistent or recurrent plug ducts or mastitis, people who want to induce lactation, things that just simply, low milk production and high milk production has its own problems too. And oftentimes lactation consultants can help with these things, but sometimes they get to a point where they need somebody who can evaluate and do a workup and treatment. And unfortunately, most physicians, even the physicians on the front line, like OBs and pediatricians and even breast surgeons, don't get much or any training in breastfeeding. So patients go to these people asking for help and they don't know how to help. And breastfeeding medicine is a new specialty that is offering a way for patients to access this kind of help.
All right, and we're going to talk more about that in your Kevin MD article. Say no to apno and yes to breastfeeding medicine. Before getting to your article, let's bring everyone up to speed. What are some common reasons for nipple pain during breastfeeding, and where does apno or all-purpose nipple ointment, where does that come into play?
So probably the most common thing is simply a latch not being quite right. So for breastfeeding to be effective and not painful for a mom, the nipple has to kind of hit the right place in the baby's mouth, so which is at the junction of the hard and soft palate. And if a baby's not latching deeply enough or widely enough or using their tongue correctly, then that may cause pain. And when there's pain, there is sometimes nipple trauma following that. Pumping also, pumps, no matter how advanced they are, which there's a lot of newer pumps that try to be as physiologically correct as possible, but it's always going to be artificial. And so sometimes pumping can cause nipple trauma. Also, infections or dermatitis or nipple trauma for some other reason can cause pain. Usually we go back to that latch. That's the most common place that we need to work, and then potentially try to heal any trauma that has already happened.
And what is all-purpose nipple ointment, and when is it typically prescribed?
Yeah, so all-purpose nipple ointment is a combination of a steroid, an antifungal, and an antibacterial. This is usually obtained at a compounding pharmacy that can mix all of these together. Some people just make it themselves. And the purpose is to treat whatever it is that's causing the pain. And it's not usually, as we know in medicine, I mean, there often are multiple things leading to pain, but usually you can find a specific diagnosis to treat, not usually. Ideally, we can find a specific diagnosis to treat, but we don't seem to do that with breastfeeding. And with nipple pain, all-purpose nipple ointment is kind of a catch-all, like, okay, there's pain. It might be one of these three things, so let's treat with the nipple ointment. And oftentimes it does improve, which has probably facilitated the fact that this gets used again and again, because sometimes just a barrier or a moisturizer or just a moist environment for healing is all the nipple actually really needs. And this ointment can provide that, though it's providing it with a lot of extra things that aren't needed and they can potentially cause problems. So it is very commonly recommended and prescribed because people don't have additional training and knowledge to know how to make those diagnoses and what treatments might work.
So you wrote in your article, just echoing what you said, apno is like throwing the kitchen sink at nipple pain, and it goes
Yeah.
against your personal treatment method and decision making as a physician, partly because, as you said before, that sometimes the true cause can be elucidated with a proper evaluation treatment plan. So I think in your ideal scenario, what would that look like? What would the ideal plan be if a mom came to a breastfeeding specialist like yourself? What would the ideal situation look like?
So ideally, I would be able to see them in person. Sometimes that's not possible, and I do virtual visits. But ideally, I would want to see them in person and be able to not only physically in person examine their nipples and their breasts, but to also watch their baby nurse or watch them pump so that I can troubleshoot those kind of mechanical physical things that might be contributing to the problem. And then, of course, as we always do in medicine, actually, before I do the exam, I would do a good history to see if I can get any clues to what is happening based on the timeline and all the other factors that are going into the breastfeeding. And then ideally, I just think about how sometimes I'm diagnosing just a rash in a child that, sometimes it's like, well, kind of seems like it could be this and it could be this. It might be fungal, but it might be eczema. And I don't like to prescribe that kitchen sink. So, I go with what is most likely based on the exam and the history and all of that. And let's try this first and touch base in a few days and see whether we're making progress. And if we're not, or if things are getting worse, then maybe we need to go to plan B. And if there are ways to actually help facilitate a diagnosis, then you do that. So a culture or something like that to help you guide your management. So I really like to provide that personalized care with as much information as I can get in order to make hopefully the right decision and close follow-up to make sure that we change gears if we need to.
Now, how common is it that you're able to diagnose the true cause of nipple pain without resorting to something like apno?
Fairly common. So, again, sometimes that latch, just making a few little adjustments, moms will be like, oh my gosh, this is so much better. And if the latch is better, then usually the pain diminishes, there isn't any additional trauma, and whatever trauma was there is allowed to heal. So that's relatively common. By the time people get to me, it's been a while, and so pain might not go away immediately. But when there's trauma to the nipple, using basic wound care techniques are really what it's all about. Not these, for some reason, we have come up with these different ways of treating breastfeeding that are different from just the wound care that we would do for other parts of the body. But the nipple is a part of the body, and we treat it the same way. We need moist, closed wound healing. And that will often do the trick if you're patient and fix kind of that, whatever that trigger was. And then I actually didn't mention before, vasospasm is another cause, kind of like Raynaud's of the nipple, similar to that. That is often a cause of nipple pain and usually triggered by something else that's going on, like the latch not being right or pumping technique is triggering a problem. And so if you're able to put all of these things together, I find that maybe 90% of the time can find the one or two diagnoses that are going on and get to the root of it and get people feeling much more comfortable.
You mentioned earlier that repeated use of apno can be problematic. What are some of the issues with it? What are some of the side effects from repeated use?
Yeah, I mean, it depends. So the formulation is a little bit different depending on who's preparing it. So there are antibacterials that people can have allergies to. And so apno itself can create more of a rash or a problem, dermatitis. We see that frequently. And also just if you're using it and you're feeling a little bit better, but it's really not getting to the root cause, and that root cause may just worsen and worsen and worsen, and you don't really realize that you're not treating it correctly. And just why treat something for longer than you need to? Sometimes people will start the apno and feel better and use it for like a year when they don't really need to do that. And with the antibacterial component, they may be breeding resistance. So there's definitely ways that it can be harmful.
So, how about in a primary care setting where sometimes primary care clinicians may not have access to a breastfeeding medicine specialist like yourself? What kind of advice can you share with them when it comes to nipple pain?
Yeah, so learn how to assess a latch. I think it's really important if you're going to be working with people who are breastfeeding. If they're there in your office and that baby is there and the mom is there, watch them breastfeed and become more comfortable with watching them and assessing them, seeing what a good latch looks like. Now, sometimes good latches can still be painful. So there's a lot of things going on, and there's education out there through lactation organizations. There's some that is very much geared more towards physicians. So the Academy of Breastfeeding Medicine and IABLE, which is the Institute for the Advancement of Breastfeeding and Lactation Education. I always have to think about that one. There is physician geared education with videos and in-person conferences and all sorts of ways to learn to better assess that. And if you can better assess it, then you can find the resources. Like if you're not a specialist, you may not have the time to always, sit there for an hour and watch a baby feed, but you would also know what resources are available in your community to be able to send people to. We breastfeeding medicine doctors will often, we want to help. And so we can be contacted to give advice over the phone as well to other physicians out there who need some help. There are a lot of ways to make yourself better educated. And it really is something that just has not been the focus in medical education and training. And so we need to take it upon ourselves to find that education. Now, there is upcoming hopefully we will have a board certification for lactation medicine, and that will hopefully increase the access to education through academic programs, but also will lead to better access for patients and more places that people can go to get educated to be able to pass on the information and education to the next generation of physicians too.
One of the points that you bring up in your article is that breastfeeding medicine, like you said, is a relatively new specialty. And what's the current status when it comes to evidence-based treatments in this field?
Yeah, that's a really good question. So there is a decent amount of evidence out there, but it is sorely lacking, especially in humans, because anything breastfeeding, newborn, baby, pregnancy related, it's really hard to get IRB approval for the best kind of studies. So, the randomized double-blind studies. So we don't have that much of that. So people are working at improving the bulk of research on that. Right now, honestly, a lot of the research that we have and the evidence that we have is through the dairy industry,
Mhm.
because that is where the bulk of our focus has gone as a country in terms of getting milk from other from animals. And so we do have a lot of information there, but it's not all applicable to humans, obviously. So we do need more good research, good evidence. And again, I hope that with this becoming a specialty and a better recognized specialty, there will be more money and support and people to get this research done.
We're talking with Cindy Rubin. She's a pediatrician and breastfeeding medicine specialist. Her Kevin MD article is titled Say No to Apno, that's all purpose nipple ointment, and yes to breastfeeding medicine. Cindy, tell us some of your take home messages that you want to leave with the Kevin MD audience.
So, well, say no to apno, obviously, but really the whole point of that article was just that was an example of how there's a lot of misinformation out there about breastfeeding. And we're recording this during World Breastfeeding Week. And, one of the things that World Breastfeeding Week tries to encourage is just more education about the challenges that people have in our country as well as our world that revolve around breastfeeding. So educate yourself, find out where you can find out about breastfeeding to support your patients better. And if you have personal experience with breastfeeding and breastfeeding challenges, that is helpful in terms of being a practitioner, but it does go deeper, and there are ways to get more certification. And even if you're not interested in certification, there are ways to get better education to be able to provide the care that I think is deserved and necessary for patients. And it really is, there's a lot of pushback in the kind of breastfeeding, infant feeding, pediatrics, physician community, even towards, just don't breastfeed. Breastfeeding isn't that important. Your mental health is more important. Well, your mental health is absolutely important. And I don't think that there's any amount of breastfeeding or breast milk that is worth a mother's mental or physical health. But a lot of the time, the reason why people kind of have this default, like, just stop. It's not worth it. It's not worth it. It's okay. Formula's okay. That may be the case, but nobody should feel like they didn't receive the support that they should be able to get to at least optimize their chances of reaching their goals if their goal is to breastfeed. So we need to improve that access to patients, and the more primary care doctors and frontline doctors really who understand breastfeeding and start to learn what evidence is out there, the better people will have a chance of succeeding in those breastfeeding goals.
Cindy, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you. Thanks for having me. Have a great day.